Good morning, everybody. As Cecilia said, I am a geriatrician, palliative medicine physician at Mount Sinai, and my research is really focused on two areas in science. One is creating and disseminating models of care delivery to improve the quality of life for persons living with serious illness. And the other major area has been to look at the social, environmental, policy, and health system factors that impact quality of life for people living with dementia, which according to Bob makes me somewhat an exposomic researcher, or at least part of that area. And so what I wanted to do today is talk a little bit about the overlap between what initially I called natural disasters. I then started to think about extreme weather events, and as a colleague of mine said to me this morning when I woke up and it was already brutally hot, perhaps these are no longer extreme events, but normally occurring events. So that's the outline of where we're going today. And what I'm really going to do is talk about weather events and their impact on people living with dementia. Right now, there are about 55 million people in the world who are currently living with a diagnosis of Alzheimer's or related dementia. To put that in perspective, that's slightly less than the population of France. That's 1.5 times the population of Canada, where I'm from. It's not an insignificant amount of people. And it's a group of people right now for whom we will not have a cure for their disease, nor any of the work that we do in terms of understanding the development of dementia will impact. And so right now, most of this becomes both a public health perspective, public health interventions, and applying what we now know in terms of reducing some of the impact of socio-demographic factors on this population and their quality of life. I'm going to be talking about climate change, so I need to disclose that I'm a part-time employee of the US government, the Veterans Affairs, and the opinions that I'm going to present do not reflect the opinions of the Department of Veterans Affairs. The facts do, however. Let's put this in perspective. And I think this graphically displays what we're talking about, is that it is very clear that we are experiencing disasters, and in fact, billion-dollar disasters at a rate that we have never seen before in human history. This is just simply from 1980 up until 2024, when the US government stopped collecting data on this, the number of billion-dollar disasters that have occurred in the United States. And you can see severe storms, freezing, wildfires, drought. And for the population that we're talking about today, that is people living with dementia, this is a massive public health emergency that is hiding in plain sight. Extreme heat, or usual heat, extreme cold, or usual cold, hurricanes, wildfires are becoming the norm rather than the exception. And when we look at the data following these events, older adults account for an extremely disproportionate amount of mortality. In fact, when you look at who dies both immediately and subsequently, the vast majority of people are older adults. And when you look at that population of older adults, a disproportionate amount are living with dementia. And in fact, the mortality risk if you have a diagnosis of dementia is 3 to 5-fold more than if you're an older adult without cognitive impairment. And most of this is not captured in the data or the public reports, because the effect of these climate events are both indirect and invisible. It's death due to dehydration. It's death due to delirium, disruption of medications, the trauma of transfer or relocation. And this is often unhidden and most of the time untold. So let's actually put this down at the patient level and talk about a patient. This is a composite description of one of several of my patients that I care for, and particularly one who moved to Florida about 10 years ago, just in time for Hurricane Irma. Consider an 84-year-old woman. Let's call her Mrs. J. She has moderate Alzheimer's disease, lives with heart failure. She's got oxygen-dependent chronic obstructive pulmonary disease, insulin-dependent diabetes. By the way, insulin needs to be refrigerated, otherwise it's no longer effective. She lives with her adult daughter, who is her primary caregiver, and so her daughter can work. She has an 8-hour home health aide 5 days a week. And a hurricane warning's been issued for her town in Florida. And the questions that we have to face is, does she evacuate? And if so, where does she go, given her care needs? Who brings her oxygen concentrator with her? And who brings her insulin? Or how does she access it if she evacuates? What happens if she's separated from her daughter because her daughter is her memory? And finally, what are her goals of care if a crisis occurs? What are the medical treatments, interventions that are consistent with who she is that she would want to receive, which her local doctor and her local care team know, but are not going to be available to the team that's going to take care of her when she relocates? And if we think about climate events in the setting of dementia, people living with the disease have a unique vulnerability that others don't. First of all, because of their cognitive impairment, they often can't recognize danger. They may not recognize or identify the threat of extreme cold, heat, smoke, or floods. And therefore, the result is they won't seek help because they don't understand or know that they need to. They can't thermoregulate. One of the physiological changes that we see with aging is an inability to thermoregulate. We don't sweat as much, we don't get thirsty, and we have, compared to younger adults, impaired sodium and water regulation. Believe me, I know this when I run in the heat. I cannot run in the heat the way I used to. So what happens is somebody with dementia is unable to compensate because they don't know to seek out air conditioning. They actually paradoxically remove clothing in the setting of extreme cold, or they don't know to increase their fluid intake because they don't feel thirsty. People with dementia are dependent on a familiar place. Home is an assistive device. It's like a cane when you're walking. It provides structure, it provides normalcy, and when somebody with dementia is moved to an unfamiliar place, we get both delirium, we get agitation, and we have data that demonstrates accelerated functional and cognitive decline. People with dementia are typically older adults, and most older adults are on multiple medications. Cholinesterase inhibitors, antipsychotics, antihypertensives, mood stabilizers, all common in people with dementia, all of which, if they're abruptly stopped, can cause withdrawal symptoms, which can trigger behavioral crisis, or even worse. You can't communicate distress, particularly the later stages of the disease, which results in silent suffering. And finally, people with dementia are highly dependent on their caregivers. And if they are separated from their caregivers, safety is compromised. They can't self-evacuate themselves. They need somebody to get them out. They may need somebody to provide hydration. And they can't manage their activities of daily living without somebody there. And if that caregiver is separated during a disaster or a routine heat wave, for example, has substantial impact, which we don't see in people without cognitive impairment. So I'm going to walk briefly through the impact of 4 common adverse weather events and what the specific impact is on people with cognitive impairment. We're going to talk about heat waves, We're going to talk about cold domes, hurricanes and floods, and finally, since I'm from the United States, wildfires. So let's talk about heat waves. Heat waves for people with dementia are probably the deadliest climate hazard. And as I said before, why are they lethal? Because of the normal physiological changes that we see in aging, the impairment's inability to self-regulate, impaired thirst sensation, and for people with dementia, just the inability to recognize you're in danger, and the behavioral agitation that happens. If we look to Europe, for example, in the 2003 heat wave, there were 70,000 excess deaths reported, but the overwhelming majority of those deaths happened in people with dementia, those with limited mobility, those who were socially isolated, and those with cardiovascular disease. Again, a relatively small segment of the population, but a very large percentage of those who died. If we think about cold domes, again, something we're seeing more and more, there are dementia-specific risks. People often, because of the effect of dementia, can't communicate the cold sensation, that they're cold, and they may have difficulty calling for help. Abrupt changes in temperature, going from yesterday being, quite nice to today being freezing, causes confusion, agitation, anxiety, and fatigue in people with dementia. Imagine it's -10 outside, and your person with dementia who is just sort of doing okay at home decides to go for a walk. Okay? Not unusual. Increased risk of falls because of the ice. Much increased risk of disorientation because they start to get cold and don't know about it. And when it's -10 or -15 out there, there's not a lot of people out there. So if you fall on the ice and can't get up, there's not somebody there to pick you up and get you home. All of this contributes to increased mortality risk. And if you have a power outage, your insulin in your fridge no longer works, and any biological medication you're taking, which is stuck in your fridge, is no longer working. And people with dementia may not notice, aside from the fact your house can get very, very, very cold. Oh, just for example, Texas winter storm Uri in the United States in 2021, when we looked at who died during that storm, people on dialysis, no surprise. People who had insulin-dependent diabetes, perhaps no surprise. And the other major group were people living with dementia. And in fact, when you looked at people who were living in nursing homes who should have been protected, and that nursing home lost power, excess mortality rates of 13% in the 3 to 5 weeks following the cold freeze. Floods and hurricanes make a lot of news because people drown, people stay in place and are hit by something. But for people with dementia, it's actually a slow disaster. Most deaths that we see occur in people living in long-term care facilities and those unable to evacuate and those dependent upon medical care. And the deaths don't occur from drowning or from trauma. What we see is missed medications, oxygen, dialysis interruption, closure of hospitals, so people can't get in to get both either acute care or chronic care, caregiver loss because the home health aide that you relied upon to come in 8 hours, 5 days a week was evacuated or the agency is no longer working. So there's nobody there to come in and help. And obviously delayed emergency care. And if we look at Katrina in the United States in 2005 and Maria in Puerto Rico in 2017, again, mortality concentrated in people with dementia, the population we're talking about today. 70% of people who died in Katrina were from non-evacuated nursing homes. Highest mortality rate. In Maria, the interrupted medical care was the major cause of death in the 4,600 or so excess deaths observed. And by the way, that 4,600 is the official estimate. It was probably a lot higher than that. And it had a long-term effect because the mortality rates and elevated, accelerated cognitive decline were seen to exist 12 months to 2 years after each of these events. And this was far longer than we saw in cognitively intact individuals. So it was both the immediate effect and then the long-term effect of what happened. And then finally, wildfires, which particularly in the United States are becoming more and more common, also in Canada, where every summer now is wildfire season. We know, and I think Dr. Richard Kwok is going to talk about this, that PM 2.5 already increases the risk of Alzheimer's disease. But acutely, not long-term, but acutely, it can have an effect on people living with dementia. It crosses the blood-brain barrier, causes neuroinflammation, and so an acute exposure likely accelerates cognitive decline. Acute smoke exposure has been shown to accelerate or to cause agitation, psychosis, and behavioral crises in people living with dementia. So these people become even harder to care for in the setting of a wildfire. And there are particular types of dementia, non-Alzheimer's disease, Lewy body dementia, and vascular dementia, and frontotemporal dementia appear to be especially sensitive to the toxic effects of acute wildfires. And if we just look at the Camp Fire, which happened in Paradise, California in 2018, there were 85 deaths because long-term care facilities could not evacuate their residents. And a loss of routine can be as damaging, that is, forced evacuation can be as damaging as staying in place, because if you are forced to evacuate, you change the person's living structure. And even if you stay in place, you're confined without normal day programs, for example, that some Alzheimer's patients rely upon. You lose your routine, you can't go out and walk, you can't exercise, and again, you can see increased behavioral disturbances, which makes it very difficult for caregivers to cope. And we get a caregiver crisis, because if you are forced to stay in one place and not go out, and are 24/7 caregiving your loved one with dementia, dramatically increases caregiver stress and burden. And in fact, what we see is we see an increased rate of emergent nursing home admissions in the setting of wildfires, because caregivers become overwhelmed and need to move their loved one into a nursing home because they no longer have the capacity to care. And, even if we get people with dementia to safety by evacuating them, it's kind of a double-edged sword. Because if you think of the process, there's a warning issued. You have to decide whether you evacuate or shelter. Typically, if you evacuate, it is not a seamless transition. It tends to be relatively time-constrained and chaotic. You move somebody from a very familiar environment into an unfamiliar facility. And indeed, what we see is an increased risk of delirium and mortality. Relocation stress syndrome, 3 to 5-fold increase in 30-day mortalities in people with dementia after an involuntary transfer. When you have an emergent relocation, you're typically placing somebody into a facility that may already be understaffed, and now you're making it even more understaffed, and typically people don't bring their medical records with them when you evacuate. So you're not only bringing somebody into a facility that's not ready for them, you're bringing them without the medical records that they really need to care for them. And when we look at what happens in nursing home facilities during natural disasters, there's a 40 to 60% absenteeism rate, because those people are evacuating. So you're bringing somebody from one place to one place that's understaffed, and then you're reducing that staffing by 40 to 60%. And that doesn't even account for disasters that happened in Hollywood Hills in Florida, where after Hurricane Irma, the backup generator at a nursing home failed, and in 30-degree or US 90-degree heat that followed the hurricane, 12 residents died because there was no longer air conditioning, and nobody replaced it. If I could get one message to all of you, for people with dementia, place is a treatment, okay? Familiar cues are associated with preserved and enhanced function. Relocation results in injury, and when you displace somebody, it is a cascade of events. You get behavioral crisis, treatment with medications, antipsychotics, that can escalate things. You get a hospital admission, further delirium, and you go from somebody who was living at home to now somebody who's living in a nursing home. Okay? And beyond the mortality, disasters have a significant impact on quality of life for people with dementia. PTSD in people with dementia manifests as behavioral disturbances. It's agitation, it's fear, it's refusal of care. And we make a diagnosis of dementia progression rather than one of PTSD. Talked a lot about the fact that home is so important. You take somebody with dementia out of their home, they lose their sense of place, they lose their sense of self. It enhances the cognitive decline, and there are pretty strong data about that. Caregiver collapse, day programs close, respite is no longer available to people. You get emergency nursing home placements, and caregiver distress and caregiver burden. Talked about behavioral crises from new environments, and we see a much higher rate of institutionalization. So that people go from living at home and being cared for at home to being in an institution because of the event that interceded. And as both clinicians and policymakers, what we often don't think about is the caregiver is the disaster plan for these folks, okay? Disasters increase PTSD and depression in caregivers, and we've seen that is greater in caregivers than the general population. Housing instability may force caregivers to separate from the person they're caring for, because the caregiver may be able to go into the hotel room or the temporary Airbnb, but the person with dementia ends up in the nursing home. And adult day programs and home health agencies, which provide that added layer of support that allow caregivers to function, many of them close during these types of temporal events. It's a non-clinician audience, so I'm going to skip what the clinical implications are, but let me tell you as a doctor, there are things that you should and can be doing for these people right away. It's part of good preventive health and preventive maintenance. How am I doing time-wise? I've got a minute, huh? Doctors in the room, practicing clinicians? Anybody? I'm sort of it. Bob, yeah. All right. We can talk about what you can do during the break. But again, there are things that you can do. But from a public health perspective, there are clearly some system-based approaches that we need to start thinking about, and we need to start thinking about further research to identify them. First of all, there's long-term care preparedness. There should be no reason that an air conditioner breaks because a generator doesn't work, okay? We need to pre-identify receiving facilities so there's a clear evacuation plan, so these people are not surprised when residents show up. And we need to risk stratify by dementia stage, because people with end-stage dementia are at much higher risk than people with earlier stage disease. We need to start thinking, again, as a public health perspective, of vulnerable population registries. So we know who these people are, and we know where to go to evacuate them, and we need to know how to provide the resources when one of these events happen. i.e., who's on oxygen in your community, who's homebound, who needs regular checks afterwards. We need to do better dementia disaster surveillance. The current surveillance systems don't capture any of these patients or their caregivers. We're focused on deaths. We're not focused on the long-term outcomes. And finally, we need to really think about that caregiver and think about emergency respite for them, which we haven't done. So, 4 take-home messages. First of all, number 1 is that the population that we're talking about today are at disproportionate risk for mortality, cognitive decline, functional decline, and adverse quality of life in the setting of natural disasters or perhaps normal climate events. Most of the health consequences don't occur during the event. They occur after the disaster as a result of displacement, disrupted care, and caregiver loss. So they're indirect rather than direct. The caregiver is the disaster plan. So if you are caring for an older relative with dementia, you are their disaster plan. And we don't think about that. And finally, disaster preparedness, and disaster is probably the wrong word here because the most common problem right now is extremes of heat and cold. And those are predictable in that we're going to see them every single summer right now. And that's got to be a component of what we think of high-quality healthcare for older adults. Thank you very much for inviting me to your party. I think Bob is bringing me almost kicking and screaming, but I'm getting there. So thank you very much.
Thank you so much. Wonderful talk. Natalia Vilor Tejedor from Utrecht University. So I have 2 quick questions. The first is more related with sex differences in these results that you are observing. So,
sorry, it's a little muddled down.
Yeah, no, I wanted to say it. I wanted to understand if you observe any sex differences in the results that you were also mentioning now in the last slide. And also the other thing is more the relationship with the socioeconomical factors in all this story that you were showing us. Thank you.
So there haven't been observed sex differences, and that's probably because nobody's actually looked at it. Okay, we know that the majority of caregivers are women between the ages of 24 to 60, so it is not unimaginable that the caregiver stress, caregiver burden falls disproportionately among women. We also know that most older adults with dementia are women, just so that there is probably a disproportionate effect on women, but nobody has specifically looked at it. And you're absolutely right, there are clear socioeconomic, social determinants of health factors that play into this. The poor, much more likely to have adverse outcomes. People living in long-term care facilities, much more likely to have adverse outcomes. And certainly looking at the hurricanes in New Orleans, Puerto Rico, Florida, disproportionate impact on persons of color, people living in socioeconomically depressed areas, people without resources. Absolutely. It is the most vulnerable segments of our populations that are affected, without doubt. And again, this again calls for a public health response and public health research.